Welcome to the Fit Strong Women Over 50 podcast, episode number 163.
Hi, I'm Chris. Thank you for joining us today.
And I'm Jill. Chris and I are your hosts for this podcast and the founders of the Becoming Ellie community.
We decided to name our community Becoming Ellie because Ellie was the Norse goddess of aging who beat Thor in a wrestling match. Jill and I thought, hey, we want to be fit and strong like Ellie.
You can find out more about the Becoming Ellie community and this podcast at our website, becomingellie.com. Ellie is spelled E-L-L-I.
And if you go to our website, sign up for our newsletter while you're there. It's a good way to know what's going on with us.
Chris, I noticed that we have a number of reviews on Apple Podcasts, and the most recent one is from Marjorie 2. She wrote, "This is an inspirational podcast for women over 50. Along with a variety of guests, Chris and Jill empower women to live healthy and well for the next era of their lives. Highly recommend."
Those reviews are great. And thanks, Marjorie.
Yeah, we really appreciate it. Today, we're talking with Kim Vopni about keeping our pelvic floor healthy. I learned a lot from this conversation, and I think you will too. Let's go to the podcast. Kim Vopni is a leading authority in health and fitness coaching for women with pelvic floor dysfunction and is known as the Vagina Coach. She has helped thousands of women learn how to do pelvic floor exercises, ditch the incontinence pads, eliminate the prolapse symptoms, and get back to living life to the fullest.
Kim is a certified fitness professional who became passionate about spreading information on pelvic floor health when she was pregnant with her first child. She's the author of 2 books, Prepare to Push, What Your Pelvic Floor and Abdomen Want You to Know About Pregnancy and Birth, and a second title, Your Pelvic Floor, The Inside Story.
Kim is the founder of Pelvienne Wellness Inc. and co-founder of Bellies Inc. She is also the founder of Kegels and Cocktails, a women's health event designed to empower and educate women on the importance of pelvic health.
Welcome, Kim. It's a pleasure to have you on our show.
Thank you for the lovely introduction. Thanks for having me.
Great to get to talk with you. Can you just explain what services you offer people?
Yeah, I get asked this a lot because people think that I'm a pelvic floor physical therapist because I'm always referring people to pelvic floor physical therapy and I'm talking about everything to do with pelvic floor muscle training. My role, I'm a personal trainer. And I recognize this void. I recognize, first of all, a void in the conversation around pelvic health in general. I didn't even know about pelvic floor physical therapy when I first started doing what I do. So I started doing what I do because of a biofeedback device that I used in my pregnancies that helps you see what's happening with the pelvic floor and helps you learn to yield to stretch and pressure and discomfort. So it's trying to mimic what happens when you're birthing a baby. So I had a great experience with this product and I said, why isn't everybody using one of these? And I said to the company who manufactures it, can I be a distributor here in Canada? And I didn't intend for it to be a business. I thought I would just sell it on the side. Anyway, 20 years later, that's how it all started. And then I learned about pelvic floor physical therapy and I learned about all these other products. And so I had an e-commerce store initially. And through that process, I was selling these products, but I was working predominantly with pregnant women, wanting them to use the EpiNo to help reduce the likelihood of tearing, to help them better prepare for their childbirth. I created a program called Prepare to Push, which was bringing fitness principles into training for birth and recovery. And then I worked with 2 other women. One was a pelvic floor PT. One was another trainer like myself. And we manufactured a postpartum wrap because we were looking at this. We were providing this protocol, but really in general, the postpartum recovery was very overlooked in North America. And we wanted to take practices that are used in other parts of the world, like belly wrapping, put it together with pelvic floor recovery exercise, and then give people a plan forward. So I did that for a little while. And then, long story short, but basically sold Bellies Inc. and which was the wrap company, and put my programs online because working one-on-one was great, but many people around the world were learning about me and saying, how can I work with you? And so then I started to do more online. So anyway, now everything's online. And really what I do is I take fitness principles and I apply them to the group of muscles called the pelvic floor. So the principles of fitness like specificity and progressive overload. Just like we would train our other parts of our body, we can use very similar practices with our pelvis. So as a personal trainer, I saw a huge void, even in my own training as a personal trainer. I learned about all the other muscles in the body, all their insertion and their origin, their function. Never once did I hear the term pelvic floor or learn about what I argue to be the most important group of muscles at the foundation of the core. So I handle movement, exercise, lifestyle, and pelvic PTs are more, they also do a lot of what I do with posture evaluation and movement practices, but they also do hands-on internal. They are licensed to evaluate and treat beyond the opening of the vagina. And that is such an incredibly beneficial therapy. Those patients then need to go home and do their exercises, but many are either they might be given a sheet of paper or they might be given a little app with a few different exercises, and they're not really they kind of stay in that rehab focus. And if we get people out of the rehab and kind of into a fitness that's still addressing the pelvic floor, we have better adherence and consistency because it's now like a workout and it's now more fun than rehab exercises. So that's where I come in.
So maybe we can just start with the basics and tell us, what is the pelvic floor and why are we concerned about it?
Absolutely. The pelvic floor is a part of the body that we really can't see and we've never been given education about. It's essentially a group of muscles. So it's a large nerve supply, a large blood supply and the muscles attached to our pubic joint, or many people refer to it as the pubic bone at the front, and our tailbone at the back. And if you were to sit down and kind of pry one butt cheek away, you dig in and you feel a bit of a bone in your bum. You have one on either side called your sits bone. So those 4 points are where the pelvic floor muscles attach to. And their roles are, they help with our continence. So they manage the openings of the urethra, the vagina, the anus, and they help decide when we want things to come out, we can let them come out. And if we don't want things to come out, we should be able to hold them in. It also is a key factor in if we are birthing a baby. It allows things also from insertion, tampons, fingers, toys, penis, that type of thing. So the pelvic floor is intimately responsible for managing those openings, managing our continence. It also plays a role, the group of muscles known as the pelvic floor plays a role in supporting our internal organs, the bladder, the uterus, and the rectum, mainly. The pelvic floor also plays a role in our sexual response. It plays a role in our core stability. We've all heard of core exercise or the core, and the pelvic floor is actually the foundation of our core, but it's been left out of all of the conversations about how to activate the core. So really it's continence, organ support, sexual response, core control and stability. And the final thing is it works in synergy with our diaphragm. And every time we breathe in, the pelvic floor lengthens. Every time we exhale, the pelvic floor contracts. And that creates sort of like a sump pump inside of us to help move things through us with circulation, with lymph, that type of thing. So those are the 5 main roles of the pelvic floor. Usually we don't even think about any of that happening because if things are working as they should, it's just happening and without us even being aware of it. But because it's so involved in so many aspects, it has so many important jobs. If something is not working well, then we start to experience symptoms like incontinence. So stress urinary incontinence, meaning when we have some sort of exertion, we might have little bits of urine that leak out. Urge incontinence, where we feel like we can't make it to the bathroom in time. We get sudden overwhelming urges to have to go, and we may have a complete elimination of the bladder. Anal incontinence, so gas or stool can leak out. Pelvic organ prolapse, which is where the bladder, uterus, rectum, also the urethra, sometimes the intestines start to shift out of their proper anatomical position and they can bulge into or descend into the vagina. And there's a whole host of symptoms as it pertains to prolapse. Back pain, pelvic pain, painful sex. Again, when everything's working well, we don't even think about it. But when things aren't working well, we all of a sudden have all these symptoms that interfere with so many aspects of our life that it now becomes one of the only things that we think about because it's so central to everything that we do.
What did you say about the diaphragm when you breathe in?
When we breathe in, the diaphragm is our breathing muscle.
Right.
So it's essentially kind of underneath our rib cage, nestled like an arc or a dome. When we breathe in, ideally our ribs expand laterally, which allows the diaphragm to flatten. Like the dome is not quite as much of a dome. And what that's doing is it's it's a pressure system. It's helping draw air into the body. And what ideally is happening below the diaphragm is the belly is expanding and the pelvic floor is lengthening and expanding as well. All of that to allow air to come in. And then the exhalation is where the pelvic floor contracts and lifts. Again, this is happening without us making it do it, ideally. Contracts and lifts. The belly naturally draws inwards towards the spine. The diaphragm returns to its kind of arced or dome shape. And all of that is expelling the stale air from the body. So the relationship between the diaphragm and the pelvic floor is really key for optimal function, that the inhales lengthen, the exhales are contracting and lifting. When people think of a pelvic floor contraction or they think of activating the pelvic floor, they think of a Kegel, which is they think of it as just a squeeze. Many people think of it as just a squeeze, but there is a lift component that we need from the pelvic floor as well.
Okay. It's much more complicated than you might actually think.
Exactly. And that's why go home and do your Kegels is really ineffective. And most people, we have studies that show most people are doing Kegels incorrectly because nobody's ever been taught. It is much more involved than just go home and do your Kegels. That's not going to solve every problem and sometimes could actually create problems. So we need a much more holistic view of the role of the pelvic floor in all of the jobs that it does.
So could you go over the symptoms and the kinds of problems that occur if your pelvic floor isn't at its best?
Yeah. So with incontinence, most people know about stress urinary incontinence because we are marketed to by the pad companies that tell us that if we have those unwelcome leaks with a sneeze or throughout the day, we just have to put a pad on or put these crinkly black underwear on and everything's going to be fine. That's what we're told. So we interpret that as it's normal to leak a little bit of urine throughout the day and there's no cure. I just put a pad in and that's what I have to accept. So leaking urine, if you're not sitting down on the toilet and urine is coming out of your body, that is incontinence. Stress urinary incontinence is where that happens because of some sort of exertion. You've stood up from a chair, you've pushed a heavy door open, you've lifted a grandchild, you've lifted a bag of groceries, you've coughed, you've sneezed. So there's some sort of exertion and the pelvic floor muscles either aren't reacting at the right time or with the right amount of force needed to close the opening that prevents the urine from coming out. Then there is urge urinary incontinence. This is where it can be a trigger like seeing a bathroom, thinking about a bathroom, arriving at home and putting the key in the front door, hearing running water. There's all sorts of things that can trigger the bladder to get really excited and think that sound or this activity means we're going to the bathroom. I can't wait. I'm just going to do it now. And I get all excited and the bladder contracts. And again, the pelvic floor, if it can't respond quick enough or with enough force, the bladder will contract strongly enough that the urine will start to come out, sometimes little bits, or sometimes it would be a complete release of the bladder. You can have both of those, which would be mixed incontinence. You can also have anal incontinence where gas or stool may leak out, similar to urinary incontinence with exertion or with certain triggers. That is less common, but I would say more life altering. There's also overactive bladder, which many people who experience the urges or the frequency will say, I have a small bladder or I have an overactive bladder. They use this term and they sort of self-diagnose themselves. There is a medical condition called overactive bladder, and there are tests that people can do to determine if it is truly the medical condition of overactive bladder, or is it just that we have conditioned our bladder to signal us more than what is appropriate or what is normal. So normal voiding throughout the day, if you are well hydrated, would be every 2.5 to 4 hours. We should have the ability to hold longer if we really needed to. But if we're going to the bathroom every 20 minutes, half an hour, and if we have just a little bit of urine coming out each time, that is not a full bladder and is very often associated with behaviors that we have done, with dehydration, with constipation, or with bladder irritants. So things that are either concentrating the urine or irritating the bladder, and the bladder just wants to get them out. So caffeine, alcohol, artificial sweeteners, acidic foods, chocolate, dairy for some people, sugar for some people. So that's kind of the incontinence piece. Then we have the pelvic organ prolapse piece, which statistically is actually more common. So women who have birthed babies, about 50% of women who have given birth vaginally or by cesarean will have some form of pelvic floor dysfunction. And it can be different levels of severity. So early stage prolapse is often asymptomatic. More advanced stage prolapse is usually visible or something that you can see. There would be a bulge either that you feel or see close to the opening of the vagina. In extreme cases, it can bulge right out of the opening of the vagina. And symptom-wise, again, early stage can be asymptomatic. Doesn't mean that you won't have symptoms, but common symptoms are back pain, a feeling of heaviness or pressure, especially as the day goes on, feeling like you almost want to apply counter pressure, like you feel like vulnerable, almost like something's going to fall out. You may feel like you have something inside the vagina. If you are at a phase of life where you're using something like a tampon or a menstrual cup, you might feel that it doesn't sit properly. It gets pushed out over time. You may feel like you can't empty your bladder completely. You may feel like you have difficulty starting the flow of urine. You might feel like when you poop, you don't completely empty, or it's hard to get everything out or even have an appropriate bowel movement. Difficulty with insertion, even from like fingers or penis. If you have a male partner, you can sometimes feel like there's something in the way almost. Those are the most common symptoms with pelvic organ prolapse. Then we can have things like pelvic pain. So that could be pain in the joints, hips, pelvis, pubic joint, tailbone. Could be pain with sex. So maybe pain with insertion, or maybe pain with touch around the vulva. Maybe pain with the anticipation. So no touch at all, but just the thought of insertion or touch can create pain. So there's vestibulodynia, which is the opening, pain at the opening of the vagina. Vulvodynia, pain in around the vulva. Dyspareunia is a general term for painful sex, but we want to get to the root of why is it painful? Is it muscles that are too tight? Is it a low estrogen state? There's lots of different nuances under the pain umbrella, but low back pain is very, very common. Over 95% of women with low back pain have some form of pelvic floor dysfunction. So that's the three main buckets: pelvic pain, organ prolapse, incontinence, and some of the more common symptoms associated with each.
Wow. It's a lot more complicated than I thought it was going to be.
Going back to the incontinence for a minute. So if you had those two different types, does the same thing cause those? It just appears differently for different women?
Well, there's different contributing factors. So with stress urinary, let's start with stress urinary incontinence. We can have, just by aging, we have muscle loss. So that's called sarcopenia, age-related muscle loss. So losing muscle mass is one contributor, but we also, especially post-menopause, lose more of the type 2 muscle fibers. So in our skeletal muscles, we have type 1 and type 2 fibers. Type 1 are like the endurance runners. They're the long, slow hold. Then we have the type 2 fibers, which are the sprinters. They have to react very quickly. They get tired very easily. We lose more of the type 2 muscle fibers as we age, which is part of what makes us more prone to leaks, because our muscles are losing the ability to react quickly, if that makes sense. So the changes to musculature is one component. We may have changes to the bony scaffolding to which the muscles attach to. So hip replacements, knee replacements. Many people have had falls on their tailbone, that type of thing. So that can be a contributing factor. Tension or laxity. So that if we don't have the right balance between kind of effort and ease to some extent within the muscles, if we're holding on to more tension than what would be considered optimal, tight muscles are weak muscles and they will not be able to react at the right time with the right amount of force. Same with very lax muscles, muscles that really don't have a lot of tone, are also going to be hindered in their reaction time and the amount of force they can generate. It could be fear. It could be trauma. It could be pregnancy and childbirth. So injury from pregnancy and childbirth, tears, if we have scar tissue that's remaining from a childbirth or another type of surgery or another fall, that can hinder muscle function as well. Constipation, when we're not pooping well, we could maybe not be pooping well because we have tight muscles, but even if we don't have tight muscles, we still might diet-wise not be pooping well. And if we're straining to get that poop out, that's damaging to the pelvic floor. And if we have retained stool, that can contribute to sensations of urgency and frequency also from a bladder perspective. There's a whole host, that's not even an exhaustive list. There's a whole host of things that can contribute to, that's incontinence. The organ prolapse piece, very similar in a lot of these things. scar tissue, pregnancy and childbirth. Oh, I forgot to say one thing on the incontinence piece, which is hormonal changes, especially the lack of estrogen. We could argue with testosterone in there as well. And then, so with prolapse, pregnancy, childbirth, falls, scar tissue, anything that's impeding the muscles. So tension, laxity, anything that's not allowing the muscles to provide as much support as we need to the organs. But there could also be damage, specifically with vaginal childbirth, to the structures that are supporting everything on the inside. So there are some cases where all the exercise in the world will not fix a prolapse. The same could be true to some extent with incontinence as well. But if there's a damage to a structure beyond what exercise can repair, so ligaments and tendons, that could potentially be something that wouldn't necessarily change unless there was some sort of potentially a surgical intervention. But for the most part, we can make significant change with exercise. Posture can also be a contributing factor to, there's some evidence about hyperkyphosis, so really rounded upper backs being a contributor to the development of pelvic organ prolapse. Longer pushing stage in childbirth. Cesarean doesn't make you immune. So even people with cesareans can experience pelvic organ prolapse as well. Yeah. So there's a lot of constipation. I think I've said that already, the chronic pushing. It's like birthing. Obviously we're not pushing for 4 hours, 10 hours, but if you're really straining multiple times a day or multiple times a week, that's like a tiny little mini childbirth over and over again, which is really damaging to the pelvic floor.
Huh. So really this affects probably
everyone and everything. Yes.
Yeah, most women, I was going to say. And I assume men too, but
men have pelvic floors as well. They do not have a vagina. They do not have a uterus. They do not have the hormonal fluctuations that we do. They do not become pregnant and give birth. So they are at much significantly reduced risk compared to people with female anatomy. However, where challenges for pelvic floor show up for men is with prostate issues, prostate cancer. That's the most common. Men can experience pelvic pain throughout their life cycle, but from a continence perspective, it's usually to do with, or most commonly associated with, prostate challenges.
Okay. And they're less likely then to be the person walking in the door and saying, "Get out of my way, I'm heading to the restroom."
Yes.
Our listeners are women over 50, so we're either in perimenopause or postmenopausal, and most of us are done having children. But what issues does aging or hormonal changes cause in regards to the pelvic floor?
Huge. And an important point to make is that you don't even ever have to have been pregnant or given birth at any point in your life to experience pelvic floor dysfunction. So your risk is definitely increased if you have been, and it increases the more babies you have given birth to, but it does not make you immune. So anybody, literally anybody, can experience pelvic floor challenges. Young women can experience pelvic floor challenges. With regards to the hormone piece, a lot of women who are still in their fertile years, who are still having a menstrual cycle, will not always, but if they are starting to experience pelvic floor challenges, they will notice that their symptoms are often increased around the time, like the days before their period starts, where we are in that low estrogen state. So as we are getting ready to bleed, where our estrogen is declining, and that is a glimpse into what is happening or what will happen in perimenopause, postmenopause, where we are in an estrogen depleted state. The difference when we're fertile is that goes back up again. Highest around ovulation is where we have the most, kind of the highest levels of estrogen. That's where usually people feel the best from if they are dealing with pelvic floor challenges. And then the week before again, and around the start of their period, they may feel more symptomatic, more leaking, more urges, more heaviness in their pelvic floor from prolapse, more pain potentially. So I always say if we have younger women in our lives, we need to get this education to them much earlier in life. Unfortunately, so many people are learning this when they are already dealing and maybe have already been dealing for years with these challenges. And if we were to plant the seed much earlier in life, when kids are learning about bodies and sexual health and menstruation, we could impart knowledge about the pelvic floor and all of how important its jobs are and all the things that we go through as women. I really think that would change so much for the life cycle of pelvic health. But from a perimenopause, postmenopause perspective, in perimenopause, we have these fluctuations that are happening. Progesterone is typically the one that's declining first. That could potentially interfere with our digestion and our elimination, our mood, our anxiety. And when we are feeling more anxious, we will have more tension, which can then in turn create more symptoms of urgency and frequency in the pelvic floor as well. As we then, ideally as we get through that chaos and now we've reached our menopause and we are post-menopause for the rest of our life, where we aren't dealing with that cycle of a little bit more estrogen, a little bit less, and up and down like we normally do. And now we are just in a low estrogen state. Unless we replenish that with vaginal estrogen hormone therapy, we are in a low estrogen state. Estrogen plays a key role in maintaining the integrity of the tissues within the walls of the vagina, in and around the bladder. Support plays a role in muscle protein synthesis. So when we lose our estrogen, we lose a lot more. We lose a lot of support. And anybody who has maybe they haven't had symptoms along the way, and now when estrogen is gone, now those symptoms start to show up for the first time. Or somebody who's maybe had I leak a little bit, if I was to jump on a trampoline, I'd probably leak a little bit, but generally they're not too bothered. Then they reach their menopause, estrogen's now gone bye-bye. And now all of a sudden, those symptoms that were not a big deal are all of a sudden becoming a much bigger deal. So things can show up for the first time, or they become bigger problems. The pelvic floor and the bladder are screaming at us a little bit more once we are post-menopause. And it's actually a little bit beyond. So it's not like we reach our menopause and immediately things change. It's usually within the first 5 to 10 years afterwards. There's a term called genitourinary syndrome of menopause. It used to be called vaginal atrophy, and vaginal atrophy was not the most pleasant of terms, but it was also very limiting.
You're not
because
kidding.
Yeah, it's limiting in the sense of that's not the only thing that's happening. So the big term GSM, genitourinary syndrome meaning a collection of signs and symptoms. There's genital symptoms and changes. So the appearance of our labia, the clitoris, all of the tissues in the vulvovaginal canal can change and thin and dry out. So the genital symptoms can be the appearance, can be burning, irritation, itchiness. We can have urinary symptoms of stress, incontinence, urgency, frequency, even anal incontinence as well. We may have again feelings of prolapse. The symptoms may become more pronounced. And then we also have sexual symptoms. So painful sex, difficulty with orgasm, not as much sensation, maybe even inability to accept insertion. And again, that's not an exhaustive list, but those 3 categories are what is under that umbrella of GSM. The gold standard treatment is pelvic floor physical therapy and vaginal estrogen. Unfortunately, estrogen has become like a 4-letter swear word, and people are afraid of it because of a misrepresentation of one very large study that created a whole bunch of fear, and a whole generation missed out on the benefits of estrogen.
You don't have to have given birth. You don't have to have gone through childbirth at any time, whether it's early or late in life. That doesn't matter. It's the trauma to the body or the muscle change or whatever.
Correct. Yeah. It can be trauma related. It can be just adaptation. If we, heavy occupational lifting, for instance, is one of the factors that can increase the risk of pelvic floor dysfunction, specifically prolapse. So if somebody was a mail carrier, they are carrying heavy loads for multiple hours, multiple days a week, that can be an increased risk. If you have asthma or emphysema and you're chronically coughing, if you are a smoker, if you have a connective tissue disorder, if you are chronically sitting, sedentary lifestyle, but also sitting in a specific kind of tucked under posture, hunched over posture, those are all things that can contribute, and that can happen at any stage in life, again, regardless of whether you've become pregnant or not.
So let's talk a little bit about what can we do about it. It seems like the typical advice for incontinence or pelvic pain is to lose weight, maybe do some exercises. Can you explain a little bit more? Is this accurate, or is there something more specific?
Yeah, if you have excess weight, so not so much just BMI. BMI can be a little bit misleading because you can have somebody with a lot of lean body mass who would show as obese per se. But if you are carrying excess weight, that excess weight is also being managed by the pelvic floor. So if you have more so fat to lose, then yes, that can alleviate symptoms for some people. Exercise in general, so resistance training, walking, cardiovascular, that will benefit our whole body and can benefit the pelvic floor. However, we do know from research that that is not enough to actually target and train the pelvic floor, especially if we are wanting to overcome symptoms. We do need targeted pelvic floor muscle training. I had said earlier, the gold standards really, especially for the population of peri and post-menopause, would be vaginal estrogen and pelvic floor physical therapy. Pelvic floor physical therapy is a way to then learn how to do the exercises. You don't have to see a pelvic floor physical therapist to learn. And that's kind of myself. I am not a pelvic floor physical therapist. I do not see people in person. I have online programs, but I can help people with posture and visualization and cues that help them access this group of muscles that we can't see. The benefit of seeing somebody in person, which I recommend every single one of us do at least once a year, even if we have no symptoms, the benefit of that in-person visit with a pelvic floor physical therapist is they can look externally, which we can do ourselves, but they can look externally to see skin changes. They can look for scar tissue. They then assess internally with a gloved finger to assess the position of the organs, to assess the response of the pelvic floor, to see if you are doing a Kegel correctly. Can you contract, lift, and can you let go? They evaluate the tone between the two sides. A great therapist will also assess you in a standing position because the influence of gravity will also change how the muscles react and the position of the organs. And back to the conversation about educating younger people. When I was young, I remember being in 6th grade and a dentist came to I think it was even earlier than 6th grade, but elementary school. A dentist came to our class and we chewed on these little pink pills and it showed all the areas of plaque. And we were sent home with very strict instructions on how to brush and how to floss. And so that seed has been planted in our mind that we brush in the morning and we brush in the evening at least twice a day and we floss. And then we go see the dentist once or twice a year for a checkup. And we go to the dentist faithfully. We have a checkup, even if we don't have any toothache. And when we get a clean bill of health from them, we go away, but we don't stop brushing and flossing. We carry on with that routine. And if that seed was planted from a pelvic health perspective, where we are taught the importance, like how to do them, and also the importance of doing pelvic floor muscle training, and that we should see a pelvic floor physical therapist once a year for a checkup so they can screen for the development of incontinence. They can screen for skin changes. They can screen for pelvic organ prolapse. We can then intervene or do things differently, or it's like a vital sign almost. If we're chronically constipated and nobody's asking us about our constipation, we are damaging our pelvic floor. And if we were checking in with somebody once a year who would ask us those questions and evaluate what's happening, we could get on top of that rather than wait and suffer in silence for years and years and years and things progress and get worse. Number one thing I always recommend, again, even if you have no symptoms, but especially if you do, is see a pelvic floor physical therapist once a year, at least once a year. Then you need to be responsible for some sort of pelvic floor muscle training routine. My approach, like if we've heard anything about the pelvic floor from an exercise perspective, it's Kegels. Kegels are Dr. Kegel. He was noticing that his postpartum population was having more difficulty contracting and relaxing their pelvic floor. So he used biofeedback to help these women connect with the muscles and learn how to contract and relax. And that's where the Kegel exercise came from. What's happened over time is people think of a Kegel as just a squeeze. And because really no one's ever taught us, people interpret that squeeze as squeezing their inner thighs, gripping in their glutes, sometimes holding their breath and bearing down. So not doing a Kegel correctly. And then if they consistently do that, they say Kegels didn't work. It's not that the Kegels didn't work, it's that it was done incorrectly. And obviously, if it's not done correctly, it's not going to work. But we have loads of evidence to show when done correctly, when done consistently, Kegels, they're very evidence-based. The limiting factor there, in my opinion, is we aren't training the pelvic floor dynamically. Most Kegels are static. You sit, you stand, you lie down, and you do your exercise. But most of the symptoms that people may be struggling with happen when we are exercising, when we are walking around in the day, when we are moving. So we need to train the reaction time again and train the pelvic floor dynamically. So I bring the Kegel coordinated with the breath into a whole body movement practice, because then we're also addressing heart and bones and muscles. obviously the pelvic floor muscles, but the rest of our musculature, musculoskeletal system as well. Pelvic floor physical therapy, pelvic floor muscle training consistently for the rest of your life, just like you brush your teeth every day, you do your pelvic floor muscle training every day. And then once you are approaching or moving beyond menopause, vaginal estrogen is the gold standard. And this is not something, again, that I would say, wait until you have the symptoms. We have statistics between 50 and 80% of women will experience some or all of the symptoms of GSM, genitourinary syndrome of menopause. And it's not one of the symptoms of menopause that improves with time. So it's not like eventually hot flashes go away. Eventually the mood swings die down. This is for life and will get worse. And one of the biggest increased risks that we have when in a low estrogen state is UTIs. And UTIs they can become life-threatening. And I don't know that sounds very kind of alarmist, but it's true. Frequent UTIs treated with frequent antibiotics disrupt our gut, and we also become antibiotic resistant. And when that happens, we can get to a life-threatening state. So if there was one reason to start using vaginal estrogen, it would be the reduction of UTIs. But of course, there's a whole host of other things that can help with. So vaginal estrogen, vaginal moisturizer can also be helpful, and lubricant for sexual activity. Vaginal DHEA can also be helpful. It's basically helps with the conversion of testosterone to estrogen. Some people use estrogen and DHEA on alternate nights. Typically, vaginal estrogen is a twice a week dose, but the dose would be prescribed by your physician. But I've never been one to wait for symptoms. If I have knowledge that can help me prevent, I'm going to intervene early. And definitely with vaginal estrogen, I recommend that you around the start of your menopause, if symptoms indicate, but I would get on vaginal estrogen and stay on for the rest of your life.
So if you are in that group of women who basically lost out on estrogen, is there at some point where they would say, well, now you're too old to begin with vaginal estrogen?
Never too late.
Okay. So it is something that if you've been in postmenopause for 15 years, you could still go and your doctor would prescribe that for you.
Correct. And there are some different schools of thought with regards to when you start vaginal estrogen. Some doctors will have you start with what's called a loading dose, where you would do once a day for 2 weeks and then go to twice a week, or sometimes 3, depending on what your doctor recommends. Some people notice, especially if they have been in an estrogen depleted state for a longer period of time, that introduction of all of a sudden from none to a whole bunch of estrogen, well, it's low dose, but still more frequent use of estrogen, can sometimes create some irritation. Sometimes people end up even having a bit of a yeast infection from it. So many of the practitioners that I follow, one in particular, Dr. Kelly Casperson, who is a urologist, she just starts everybody with twice a week. So the school of thought is, if you've been without estrogen, let's give you a loading dose. However, sometimes if you've been without estrogen and you do the loading dose, you might notice some irritation, which not many people want. So if we just start with twice a week, and regardless again of what age you are and how long you've been without.
Do you go to a urologist or a gynecologist, or does it matter what type of doctor? Is there one type of doctor that's going to be more likely to prescribe that for you?
Any medical doctor can prescribe it. It depends who you have the relationship with and who you want to see. Anybody can recommend. In Canada here, at least, we have a few provinces where naturopathic doctors can also prescribe. That's not across the board in Canada. I'm not sure about the different states in the United States if naturopaths have prescribing authority for menopause hormone therapy, but to my knowledge, at least in some parts of the states, you can. Most commonly, though, it's a nurse practitioner or a medical doctor.
How do we know if we're doing the Kegels correctly, or what kind of exercises can we do to strengthen our pelvic floor?
So the gold standard would be to go see a pelvic floor physical therapist, because they can do the internal evaluation with you. And some of them even have biofeedback devices that allow you to see. So if you can't necessarily feel, you could see with maybe an ultrasound or another form of biofeedback. There are some biofeedback devices that you can purchase yourself. So if you didn't have access to a pelvic floor PT, or you didn't want to go, you could use one of the biofeedback devices available. There's a very well-known one called PeriFit that you've probably been marketed to on social media. There's another one called the LV, and they can play a role. However, they don't always distinguish between the squeezing of the inner thighs or the bearing down. So they're not 100% accurate in terms of determining if what you see registering on the screen is actually because your pelvic floor is activating. So gold standard for sure, pelvic floor PT. However, we also have our own fingers. We may have a partner. That partner may have fingers. The partner, if it's male, will have a penis. And so something that's inserted, whether it's our own or somebody else's, if we are like, if say there's fingers inserted, which would be like a pelvic floor PT appointment as well. A Kegel is essentially like a hug. We want the muscles to hug the fingers and almost gently draw them up and then let go. And so if we are, whether it's our fingers or our partner, if we don't feel a hug or we don't feel like there's a bit of a lift, or maybe we feel a little bit of activation, but we don't feel like there's a lot of relaxation that happens, that is telling us some information. So ideally, we should feel the hug. We should feel a gentle sort of drawing up motion, and we should feel that we can let that go. And if we don't, it doesn't necessarily mean like my pelvic floor is broken, it's not working. It could be that it's tight and there's not a lot of room left to generate force because it's already been used up. It could be that maybe there's some scar tissue or nerve damage that's impeding one or both sides of the pelvic floor muscles. It could be that you're not using the right, like you're not activating the right muscles, and maybe you are squeezing thighs or your glutes. You or your partner would probably notice if that's happening. But the true best way would be see a pelvic floor PT or use some sort of a biofeedback to help. The cueing that I give to people, the one that is the most commonly, like when I poll people and say, what's your best cue? I give a whole bunch of different ones. Imagining picking up a blueberry with your vagina and your anus is the one that is the most commonly preferred. So when we take a breath in, if you remember at the beginning, we were talking about inhales are where the pelvic floor lengthens. So the belly expands, the pelvic floor lengthens and expands. And then when we exhale, that's when the pelvic floor contracts and lifts. So that's where people think that is the only part of a Kegel is the activation point where we would exhale and imagine we had a blueberry at the opening of the vagina and the anus, and we would pick it up. So we would grab it, lift it up into the body, and then we would put it back down as a whole blueberry. So don't make juice. You want to put it back down as a whole blueberry. There's other cues like I like the jellyfish. So inhales are where the jellyfish is soft and floaty. Exhales are when when the jellyfish kind of gathers and propels itself upwards. Some people think of, there's this toy machine that's like a claw, and kids put money in, and then the claw, they maneuver it and they pick up a teddy bear. So you can think of your pelvic floor like the claw that's picking that teddy bear up and then dropping it usually right when you think you've got it.
These are all great visual metaphors.
Yeah. And there's no best cue. There's what's best for you. So I go through a series of different cueing with people, and they try them all and they see which one resonates. Sometimes people are like, I like the blueberries for the pickup, and I like the jellyfish for the let go. So they can have a combo cue. But it's really, we're trying to use imagery to access a part of the body. We can't go and yes, you could put a mirror in between your legs, but you wouldn't really see much happening. In the mirror, I can go and I can flex my bicep and I see it. And that makes it easier for me to access. So we need some visualization and mental imagery to help access.
Just like so many exercises, having the right form is everything.
Yeah.
And using the wrong form really doesn't do what you want to do.
Right.
So is there other exercises besides the Kegel?
Yeah, Dr. Bruce Crawford is a urogynecologist from Reno, Nevada. And we met on Twitter back when Twitter was new. Now it's called X, but way back when Twitter was new, I was trying to reach out and find other people who were talking about this new passion of mine, which was pelvic health. And everything that I had read up to that point was you have to isolate the pelvic floor. Nothing else can move. The abdomen has to be quiet. And I kept thinking that doesn't make sense to me. It's not working in isolation. Anyway, I found randomly Dr. Bruce Crawford on Twitter, and he, as a urogynecologist, performs surgeries, and he would see the same person sometimes several years later. And he'd say, well, hold on a minute. I'm a good surgeon. Why did that not work? Why are they back with the same problem? And he said, this is really a fitness issue. And yes, there are times when surgery can play a role, but it started to shift his thinking to say, let's intervene with fitness principles first. And so he used wireless EMG to look at the pelvic floor, the inner thighs, the glutes, and the deep abdominals. And he examined over 150 different exercises, and he wanted to see first of all, which exercises recruited the pelvic floor the most, and where in that exercise was the pelvic floor most engaged. So he would hook the sensors up onto the participant. They would have their clothing on. They would be filmed doing the exercise. And then there was another film that would have the readings of the EMG. And he could then evaluate all these different movements done by many different people. So it was about 150, and he narrowed it down to 10 moves that were shown to use the pelvic floor the most. And then he showed where in that movement the exercise was most engaged. And then he used, similar to I do with the core breath, voluntary activation and relaxation of the pelvic floor to harness that, basically. So I worked with him for a couple of years and helped him teach his course. He hooked me up to his wireless EMG because I wanted to play around with what changed with the breath. And, but anyway, to answer your question, squats, lunges, bridges, a couple of exercises that are not common that he named, but he named one called the butterfly, not the butterfly stretch from yoga, but if you are laying on your back with your ankles pressed together. So if you can imagine these, your ankles pressed together, and you can open up your knees and draw them in, open up your knees and draw them in. You can put a ball in between your thighs. There's another one where you are in a tall kneeling position, and you would lower your bum down to your heels and then rise back up. So those are a few of them that were on that list. And there was also a cool piece of research, not from him, but it was looking at what they called the combo maneuver. So they compared Kegels alone with an exercise that incorporated the inner thighs, the glutes, and the deep abdominals, the transversus. So very similar to the thinking that Dr. Crawford had. And they found that the combo maneuver was more effective. So to give you an idea, even like a squat exercise where we had a ball or a cushion or something in between our thighs, you lower down when you inhale and you lengthen the pelvic floor as you're lowering down into your squat. And then when you stand up, you're exhaling, picking up your blueberries, you're applying a gentle squeeze with the ball. So that's activating the inner thighs a little bit more. Just by nature of doing a squat, you're activating your glutes. The pelvic floor works in synergy with the deep abdominals, the transversus abdominis, and they're active even just doing that exercise as well. So that's just one example of kind of a whole body approach versus an isolated Kegel approach. And even two other pieces of research have recently shown, one was an elderly population of women who did Kegels prior to a resistance training program. And there was another piece of research that was looking at Kegels done as part of a resistance training program. And people were noticing benefits more quickly than doing Kegels alone, and more efficacy, essentially. So they're catching up with my bias and Dr. Crawford's bias in terms of being more dynamic with pelvic floor muscle training, not just Kegel exercises.
Good. Thank you.
I sometimes wish that everyone didn't love squats so much. And one more thing to be thinking about, like don't bend over, keep your legs, whatever. Now anyway, I'm just
one more
thing.
Well, think of why we should be doing squats, right?
Yeah. You know what? As we age, many people, especially with pelvic floor dysfunction, they're told not to squat, or they think they shouldn't, or maybe they are more symptomatic when they do squats because they haven't been told how to optimize their pelvic floor or manage the pressure of that movement. And so then they stop. And then guess what happens? That movement becomes much harder, and the amount of intra-abdominal pressure they generate becomes even more. And what do we do? Ideally, usually about 10 times a day, we go to the bathroom. We have to be able to get down and off the toilet. We have to be able to sit down and stand up from a chair. God forbid, we have to be able to get up off the floor if we fall. And I feel like the restriction of movement and telling people things like that's bad for your knees or that's harmful for your pelvic floor is actually creating more limitations and making life harder for people, rather than the opposite, where do more squats, let your knees go over your toes so that the body can adapt, so that the pelvic floor can adapt, so that we are more resilient as we age.
All right. That makes perfect sense to me. What else can we do to improve our pelvic floor? I mean, food, supplements, anything like that?
Let's start with hydration. So many people who have been experiencing pelvic floor dysfunction, urgency, frequency, stress incontinence will start limiting their fluid intake because they think if I don't have any fluid, then I won't leak, then I won't have urges. And it sounds logical, but the urine will then become a lot more concentrated, which will irritate the bladder, which will signal the bladder to, I want to get it out. So we need to drink more water, not less, in terms of helping with our symptoms. Ideally, 2 to 3 liters of water spread throughout the day, stopping 2 to 3 hours before you go to bed. We should not be waking multiple times a night to pee. After the age of 65, could maybe accept one time, but even then, that we should not be waking. We should be able to sleep through the night without waking to pee. Yet so many women are up every 2 hours sometimes going to the bathroom. And oftentimes we're not waking up because our bladder woke us up. We're waking up from a hot flash. We wake up from a snoring partner. We're snoring, a loud noise, like all sorts of different things can wake us up. And then that sudden we're like, oh, and there's a kind of a spike in cortisol. We can get anxious. That can sometimes bring on bladder symptoms, or we just think it's our bladder. So we go. And then it's a conditioned response where the bladder's like, oh, it's 2 a.m. She likes to go now. I'm going to signal her. Oh, it's 4 a.m. She also likes to go now. I'm going to signal her again. So it's a conditioned response. It's like Pavlov's dog.
Right. I woke up, so therefore
exactly.
I must go to the restroom.
May as well. I'm already awake.
Exactly. Yeah.
Does it make a difference if you go to the bathroom more often, that you will have to go to the bathroom more often?
Yeah, because we're training our bladder to go
more often.
Rather than allowing the bladder to reach its point of being full where it should say, okay, we have to empty now. If we chronically empty before we reach that point, then the bladder adapts and it's like, okay, this is where you're full, not here. Sorry about that. Let's switch our mechanisms. I'll signal you at like about 1.5 cups of liquid would be considered a full bladder. We can hold more than that, but that's generally what would be an appropriate amount to eliminate. Like a 12 to 15 second elimination, steady stream. Many people sit down and it's like maybe a bloop, 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 like kind of an interrupted stream. And it might maybe be like 3 seconds or 5 seconds. That is not a full bladder. And so the more we become aware of that, the more we can, when we get a signal, we can use a bladder diary. We can say, well, hold on a minute. I just went half an hour ago. I haven't had bladder irritants. I've been drinking my water consistently. I'm hydrated. I haven't had a huge volume of liquid. So this is an inappropriate urge. And then we can intervene with distraction techniques that can help dampen that urge. So curling our toes, maybe doing pelvic floor activation and relaxation, calf raises, sitting down and applying counter pressure. And we wait for that bladder, that signal to subside. And then we carry on throughout our day. So bladder training is huge. We think of, we potty train children, but we kind of need some more potty training as we get older as well. So that's a hydration piece. Hydration is also going to help make sure that we poop well. If we are not drinking water, we are not pooping well. And when we're not pooping well, we are straining, and that's damaging to the pelvic floor. And it's also going to create symptoms of urgency and frequency. So drinking more water is going to be so helpful. And that is always at the top of the list when I start working with people. Get your water intake optimized. And let's make sure you're pooping well, because we could do all the other exercise in the world, but if you are straining to poop and dehydrated, we're never going to get the results that we want. So hydration, eating, diet-wise, we want to make sure we have a good amount of fiber. We want to make sure that we're managing our blood sugar, because blood sugar dysregulation is also another reason why we might be waking up frequently at night. And the body is going to be producing more urine to get out that excess glucose at night. So we want to manage our blood sugar. And as we get post-menopause, we become less insulin sensitive. It's harder for us to manage our blood glucose, our insulin levels. So we really need to work hard and make some dietary changes. Potentially, I do recommend hormone therapy as well, and making sure we have enough diversity in our food, enough fiber in our food, so that we are, again, pooping well and we are getting the toxins out and we are not straining when we go to the toilet. The lifestyle piece is kind of around what we've talked about a little bit about behavior. So stop going pee just in case. Don't pee every time you leave the house. Don't pee because you think you should. Don't tell our kids or grandkids to do the same. Pee when you have to, and if you're tracking, use a bladder diary to track your food, your water intake, the symptoms you have. And that can help you notice patterns like, oh, every time I have a coffee, I have to pee more urgently and more frequently, because caffeine's a bladder irritant for most people. Or, again, the timing where I have a signal now, but I just went half an hour or 45 minutes ago. I shouldn't have to pee right now. So I can intervene with the distraction techniques and calm that sensation down. That's from a lifestyle is changing the behaviors that we have that may be contributing to some of the symptoms that we're experiencing. Posture, how we're standing, how we're sitting. If we're chronically sitting and standing with a tucked pelvis position, the muscles are going to adapt to that short, tight state. They're not going to be able to react at the right time with the right amount of force. Supplement wise, I've actually just yesterday launched a line of supplements because I recommend lots of different supplements and I wanted to make them very targeted to the pelvic floor. So creatine is one that I recommend for our whole body, not just the pelvic floor, but I don't want to leave the pelvic floor out of the conversation around muscle health and how creatine can help with our muscle. It can help with bone. Really cool new research is also showing benefits to our brain as well. So creatine, especially post-menopause, oodles and oodles of research. It's the most researched supplement, I believe, on the planet. I do have articles about all the supplements I recommend on my blog, on my website at vaginacoach.com as well. So creatine is one. Sea buckthorn oil. Oral intake of sea buckthorn oil is helpful for vaginal dryness. I wouldn't say that I would use that instead of estrogen. I still believe there's a vital role for vaginal estrogen, but sea buckthorn is an omega fatty acid, which there's benefits, again, lowering inflammation, whole body benefits there, but also specifically targeting the dryness of the tissues as we're aging as well. I created a probiotic as well that I named Pooforia because it helps optimize our gut and helps make sure that we're pooping well. So those are the three that I have launched. I'm trying to think what other ones that I would recommend. Magnesium citrate and oxide are most helpful for constipation. Magnesium bisglycinate can also help from a relaxation and calming perspective, which can help calm the pelvic floor, can help make us poop better too if we're allowing the muscles to relax better. And then, of course, I do recommend hormone therapy, both vaginal and systemic, bioidentical vaginal estrogen, as well as bioidentical systemic estrogen and progesterone. So it's always said, well, if you don't have a uterus, you don't need progesterone. I argue that even if you don't have a uterus, you still need progesterone and could benefit from progesterone.
You said 2 to 3 liters of water?
Yep. Which sounds like, oh my God, if I go to the bathroom all the time, how the heck am I going to drink? Right? It sounds like a lot of water. Minimum is half your body weight in ounces. And that's like bare minimum. If you are exercising, it should be more. And I find a general rule of thumb, 2 to 3 liters spread out over the day, stopping about 3-ish hours before you go to bed will keep you well hydrated, make you poop well. And it's the start of the day water I find that really makes a big difference as well. So waking up and having even up to half a liter, sometimes even up to a liter, right when you wake up to start the things, helps with digestion, gets things flowing. So some people will pee a little bit more because of the volume in the morning, but it just kind of sets the tone for hydration. Adding electrolytes is also something that can help make sure that we are retaining some of the moisture and not just peeing everything out also. And electrolytes sometimes help some people with pooping as well.
I saw on your website that you have a program to help women who are having pelvic surgery. And when is surgery usually necessary? And how do you help them before surgery or after surgery?
Yeah, really, it's a before and after, but unfortunately, that never historically is entering the conversation. Many people are told, just have surgery, it'll fix your problem, and then you won't have to do pelvic floor exercise. And I say the exact opposite and say that you actually need it even more because now you have scar tissue that is going to influence the function of your pelvic floor. And I believe that surgery is something that we need to train for, just like we train for a physical event. This is a philosophy I also have from a childbirth perspective. We need to train for childbirth. And we also need to have a recovery plan in place, so we're watching the Olympics. All of those athletes have been training with very intentionally for their event. And they also have a recovery protocol built into their training. Recovery immediately after, but a recovery in preparation for the next time that they race. And that allows us to then go on and perform another time. And if we could view pregnancy and surgery as things that we should train for, we are getting ourselves in the best state possible to undergo that surgery. And then we have a recovery protocol in place. And then, just like those athletes eventually they reach a retirement, but they don't just say like, okay, I competed and I won and now I'm done. They will go on and we will continue. And same thing with pelvic floor muscle training. Again, just like brushing your teeth. This is a lifelong journey that we have. So with surgery, I went through a pelvic surgery myself. So I had a type of prolapse called rectocele, which is where the rectum bulges into the back wall of the vagina. Of the 3 main types, so bladder, uterine, rectocele, cystocele is a bladder prolapse, a uterine prolapse, and a rectocele. Those are the three most common. Rectoceles are very tricky to heal, to fix, to improve. And so after 9 years of living with it, it was getting to the point where the symptoms were interfering with the quality of my life. And I chose to have surgery. And I debated this for 4 years. I booked it and canceled it 2 times before I went ahead with it for a couple of reasons. But one was I felt like a hypocrite. I'm here promoting pelvic health. I'm telling all the people how to do this. You don't need surgery. You don't need this. And now here I am having surgery. But what I recognize in that process is sometimes surgery is a really great option. And everything that I had been told from many of the people that I was seeing helping me manage my problem was, don't go to surgery. It's going to make it worse. Wait as long as you possibly can to have surgery. And the more I sat with that, the more I disagreed with that. Now, I will never say that surgery should be our first line of defense ever. We have to do all of the other things that we've been talking about, all of the pelvic floor physical therapy, vaginal estrogen, hydration, nutrition, consistent pelvic floor exercise, all the lifestyle stuff we need to do first for at least 6 to 12 months. If that's not moving the needle at all or not enough, then we have these other modalities, not even always surgery, but other therapies available to us, like medication, like Botox in the bladder, like Bulkamid, like surgery. They are there, but they should not be our first line of defense. And if we choose to or need to have surgery, we are then going to train for it by doing all of the things: pelvic floor physical therapy, estrogen, hydration, pooping, everything we've talked about here in preparation. So we're getting the muscles in the best state possible to undergo that chosen controlled trauma. We then have a recovery plan in place of how we are going to retrain those muscles now in the presence of change to the anatomy and also scar tissue. And we are then going to progressively load back to what we were doing. I disagree with 6-week green light. You can go back to doing everything you were doing before. I think a reason why we have a high recurrence rate with pelvic surgeries is because we don't prepare and because we aren't given a recovery protocol and because a lot of the contributing factors that brought us to having a pelvic organ prolapse or incontinence in the first place has not been addressed. And if we don't address that, the likelihood of that's why Dr. Bruce Crawford was seeing people back on his table after he'd done the surgery, because he's like, hey, I'm missing something here. I'm doing a really good surgery. I'm a good surgeon. I've addressed the problem. Why is it back again? There's something else. So all of those other contributing factors need to be addressed, improved, eliminated, strengthened, released, whatever it is, in preparation for your surgery. You then undergo your surgery. You then have a recovery protocol. And then you have kind of like postpartum recovery. I don't agree with a 6-week green light. 6-week green light to go see your pelvic floor PT. And then you start progressively loading from there.
That makes sense. It's almost like people who have weight loss surgery is that you have to do the work before and after, or it's not going to be successful.
Yeah. And people don't like doing the work. We live in a society where we just want the quick pill. We want the quick fix, and surgery sounds like it's going to be great, but a lot of people end up having other issues afterwards.
Right. So you are the Vagina Coach. It wasn't that long ago that women, anyone, even used the word vagina.
Yep.
Certainly not in public. What kind of response do you get to your name?
So I transitioned. Initially, I was called the fitness doula when I was working primarily with pregnant women and new moms. And as I started going through my own perimenopause, and my business partners also, we said, you know what, this is a whole other conversation. And doula wasn't resonating as much as that with the perimenopause and postmenopause. So I knew I needed a bit of a rebrand. And it happened because of a joke. I was speaking to a group of women entrepreneurs. I come up on stage. All the speakers had been some sort of a marketing business strategy, some sort of a coach. And I said, oh, well, now you have a vagina coach for your business. And it was a joke, but I was like, that's it. I'm going to say this word that nobody likes to say, that is contributing to the shame and embarrassment around pelvic floor dysfunction, because we can't say the word vagina. It's taboo and hush hush and embarrassing. So I'm stepping into this really uncomfortable word, and I want to normalize it. And I still, just yesterday, I had somebody, and I get but people saying, can you change the name so it doesn't show up on my credit card statement or something like that?
Oh,
wow.
Anyway, my response back is, this is a proper anatomical term. There is no shame. There is no embarrassment. And part of my mission is to stand in that discomfort boldly and help normalize, because in doing so, I hope to shift this silent suffering that so many people have been stuck in, so that we know how to ask we aren't ashamed to ask. We aren't ashamed to talk about these very common symptoms. And we also know that help exists and who we can go and speak to about it. Yes, not everybody loves it, but I have way more fans, like people who have accepted it, than I do people who don't. And that's okay. If I'm not for you, I'm not for you. And that there are other people out there who can help you. But I hope that doesn't stand in the way of really great education and information that can help you move the needle forward for your own health.
Well, we also didn't say the word menopause too much in public either. So I think we change. Language changes, and that's good.
If our listeners wanted to find you online, where would they go?
Vaginacoach.com.
Are you on social media as well?
Yes. Yeah. I'm most active on Instagram. I also have a YouTube channel with loads of free education and workouts and exercise. So any social media platform, even if you just go to Google and put Vagina Coach, you'll find me somewhere.
Well, thank you so much for talking with us today, Kim. It's been really very educational. Thank you.
Yeah, thanks so much.
You're welcome. Thanks for having me.
It was a pleasure having you. We'll talk again soon.
Thank you.
Yep. Bye-bye.
Bye. I knew that the pelvic floor was something that involved incontinence, but I'm not sure I really knew exactly what it was until we talked with Kim. She was certainly educational.
Yeah, she sure was. I really, I learned a lot in this podcast too. And I really thought it was helpful when she used the visualizations, when she was talking about a blueberry, picking up a blueberry, or thinking about a jellyfish, how it gathers up its legs and propels. Although I kept picturing an octopus when she said that, I need to really study my aquatic life a little better to visualize correctly. But, she really had some good explanations for things. And it was obvious when we were talking to her, she knows what she's talking about.
Oh, yeah. And that was interesting. So she is basically a personal trainer for the pelvic floor. So she's not the physical therapist or a doctor, but she certainly seemed to know an awful lot she seemed to know more than most doctors that I've talked to about any of these things.
Yeah, I really, I learned a whole lot about it. And I think specifically, I know several women that have gone through various surgeries and things for the problems that she was talking about. So, if you know of someone that may be considering surgery, her website and her talk, it's really something good to share with whoever that might be going through some sort of surgery with that.
Yeah. I listen to women at the gym, and I think incontinence, at least the kind where you do jumping around, is a real issue for many of us. I know, like at my boot camp class, people be like, I hope we're not doing jumping jacks. So it's good to know that we can do something about that.
Right, exactly.
Not just suffer from that.
Yep.
And you know what? I was sort of sad or surprised maybe that yet another part of our body responds well to squats.
Yeah. Well, squats are really something that we have to have. We must have. And that is, like one of the basic functional things. So squats are good.
I guess.
Keep doing them. Weighted squats, everything. Yeah.
Yeah.
Well, I'd be interested to find out what, some of our listeners are thinking. Please let Jill and I know if you have some thoughts on what Kim had to say or any experience you might want to share with us about your pelvic floor or other folks that information is always helpful and it's not always available. So please let us know.
You can leave us a message at becomingellie.com, or you can find us as Becoming Ellie on Facebook, Instagram, X, Pinterest, YouTube, and LinkedIn.
Hey, if you want to support this podcast, please leave us a review or a rating. Maybe tell a friend about us. Or, if you go to our website, you'll find out that you can actually leave us a cup of coffee.
Oh, yeah, that would be great. We really appreciate hearing from you and all the support people like to give.
Yeah, it was great talking with you today, Jill. I'm looking forward to our next episode of the Fit Strong Women Over 50 podcast.
I am too. See you next time. Bye-bye.
Bye-bye.